Hello, everyone. On behalf of the Peace of Mind Foundation and Electa, a clinical radiotherapy company, welcome to the Empowerment Initiative. This special one-off virtual event aims to provide you with knowledge about brain cancer and brain tumours, from diagnosis through to treatment. When armed with knowledge, you can feel empowered to have greater control over decisions and actions affecting your health, and we hope you leave this session with new information to take forward in your journey. I'm Kayla Behay, and I'll be your facilitator for this evening. Now for some quick housekeeping. We can see a number of you have joined, so thank you so much for taking the time. We've had some great questions submitted already, and we encourage you to ask more this evening throughout the presentations using the chat function, which you can find at the bottom of your screen. We will be collating questions throughout and answering as many as we can towards the end of the session. Now, as you've seen from the invitation, this session will be delivered by experts you can understand and people you can relate to. So let's cover tonight's agenda. Firstly, we will hear from Kevin Larkins, Manager and Community Engagement Officer at Peace of Mind Foundation, followed by Dr. Neda Hagigi, a radiation oncologist. We will then hear from Debbie Butler, who has experienced malignant melanoma that has spread to her brain and her treatment journey, followed by Dr. Jane Phillips and her experience with acoustic neuroma. We were then hearing from Jonathan Muller, who has unfortunately come down with the flu tonight, so he won't be able to join today. Kevin will be sharing his insights, though, on his experience as a nurse and a brain support worker on behalf of Jonathan. This will be followed by some Q&As at the end of the session. So let's begin with a bit about Kevin. Kevin is the Manager and Community Engagement Lead with the Peace of Mind Foundation and has extensive background in health, welfare and community services in Victoria, the Northern Territory and Western Australia. I'd now like to introduce Kevin Larkins.
Thanks very much, Kayla, and welcome everybody. Peace of Mind is really excited to be involved in this initiative, and a little bit about Peace of Mind. It was founded in 2013 by Beck Mallett and her brother Clint in honour of his wife Caroline, who died of brain cancer. And like so many in this space, what they found and what they thought they needed most was some support immediately here and now. We are passionate about the need for research, but we're equally passionate about the need for here and now support. And that's why the vision that we have as an organisation is, as it's put there, every family in Australia impacted by brain cancer will get the support they need. So that's what drives us, as well as the sense of urgency that it has to be here and now, not tomorrow, not Damani. And so that does drive us. And the other thing that drives us, which personally I think is really important, is that this is doable. It's really doable to support every family in Australia impacted by brain cancer. And so that drives us. We've grown substantially in those 8 years and now provide our mission, which is to provide support, but as well as that, and the next slide we can move on to, which I think, Kayla, is our mission, yeah? And then if we look to the next one, our services, which are retreats, which are really, we find those probably the most powerful of all because they connect people. We have men's retreats, women's retreats, family retreats, and bereaved carers. And the value of these is the retreat is an opportunity to get away from everyday life, connect with others, create a community, and that develops courage. We have the brain cancer support worker, more of that later. The National Advocacy Service, which connects people to support like NDIS, any disability support services. Since its inception in November last year, I think something in the vicinity of 150 families have been connected to over $8 million worth of packages, support services through those government funding avenues. We also have the survivorship diary, which Cass Bennett wrote and which we distribute. And that's an empowerment tool, which we get extraordinary response back from. We run support groups, and we have a very small but significant emergency financial grant system. We believe in the power of connection and the empowerment that knowledge gives, and that's why we support tonight's venture. So welcome, and let's get on with the show, Kayla.
Thank you so much, Kevin. I'm now really pleased to introduce Dr. Neda Hagigi. Neda is working out of Peter MacCallum's Cancer Centre as a radiation oncologist. She has a fellowship in intracranial and extracranial stereotactic radiotherapy. Neda is actively involved as a primary investigator and co-investigator of several clinical trials relating to stereotactic radiation treatment of primary and secondary brain tumours. She has prepared an insightful presentation for us this evening, and I'm really pleased to introduce her now. Thank you so much, Dr. Neda.
Hello all, and thank you very much for having me. I hope I can give an overview of brain cancer and brain tumours and treatment options, and hopefully if just one person here gets something out of it, I'd be happy. I'm just giving a sort of general overview to start with, and then I go into specifics in terms of radiation therapy and what we use to treat brain tumours. So the definition is really uncontrolled growth of abnormal cells in the healthy brain tissue. So that can be any part of the brain. It could be the actual brain cells, or it could be the lining of the brain. It could be the nerve inside the brain, and all the cells in the brain. So there's all different types of cells can create tumours. So we deal with malignant ones. So the primary that start in the brain are the malignant ones will be the gliomas, lymphomas, or medulloblastomas, which are more rare. Or the benign primary tumours, which could be such as meningioma, schwannoma, or adenomas in the pituitary gland. And then there's a group of secondary brain cancers, which is basically cancers from the body travelling to the brain and creating a new tumour. Next. Sometimes we look at scans and we think, how does this person function? Because tumours can be quite large and people can present with no symptoms. So there's not one symptom that you could say is alarming or should be investigated. And people generally connect headaches with potentially, oh, there's something in my head, I should get a scan. But it's extremely rare that a headache actually is representative of a brain tumour. What we focus on is people who have headaches where the pattern of headache has changed, or is a different type of headache. So it feels different than the usual headache, and that's when we would investigate further. So that could be a symptom of a brain tumour. There's other things like changes in personality, depending on where it is in the brain, that's obviously where we see the symptoms. So problems with concentration, short-term memory, fatigue is very commonly associated with brain cancer. So that tends to be one of the most common side effects associated with something else, for instance. Things like balance problems, and then there's the sort of very obvious ones with drooping of the face, or weakness or numbness in one side of the body, seizures, unexplained nausea and vomiting. And I've written there nothing. So really many patients are just diagnosed with brain tumours incidentally because they have a scan for something else. And I put Oliver Sacks' book there because it's really for anyone who's interested, or maybe not everyone, but I really enjoyed this book because it talks about all the wonderful symptoms and things that people can present with when there's abnormalities in the brain. So it's a peculiar book. Anyway, next slide. So we diagnose, the way we diagnose brain tumours is primarily not only with clinical examination, which is actually quite a sensitive way of diagnosing an abnormality in the brain. Sometimes by investigating the brain fluid, so the cerebrovascular fluid, by doing a lumbar puncture. But imaging is really the mainstay way of diagnosing. And as you know, the technology has advanced tremendously in in the last few decades. So the imaging is quite detailed these days, so we can find very small things and abnormalities in the brain. So CT scans used to be the way, but CT scans are not as detailed as MRI scans. So an MRI of the brain is really the gold standard for diagnosis and treatment of brain tumors. It gives us an extremely detailed information about the anatomy of the brain, and different sequences on an MRI scan is used for different things. And also, people often get worried about having too many MRI scans. It doesn't carry any radiation, so it's magnetic field. So therefore, we use it even for children and pregnant women. And the other one is PET scans. They are basically what we call functional imaging, where we use radioactive isotopes to detect abnormalities in the brain, depending on what tumor it is. They might uptake different substances. Other ways of diagnosing. So one thing is we can find obviously an abnormality, something in the brain, but the only way we really truly know is with a biopsy or with brain surgery, where the tissues looked at under a microscope. And next. So in terms of general overview of how we treat brain cancer or brain tumors, the immediate thing to do if someone's presenting and they have symptoms such as headaches, nausea, vomiting, seizures, and we see something on a scan, before anything else is obviously symptom management. So symptom management is often and frequently done with medication. So could be cortisol, it could be pain medication, anti-nausea, anti-seizure medication. That's then followed by surgery potentially, medical therapy, and that's advanced significantly for brain tumors, and particularly for brain cancer. Medical therapy has really changed. Again, in the last decade, we went from not having any drugs that entered the brain or chemotherapies to now really having, in certain cancers, quite magnificent responses in the brain just with immunotherapy or targeted drug therapies. And then radiation therapy, obviously, which is my field of medicine. And that's, there's ways of treating brain tumors. And I'll go into in more detail with that, but it used to be whole brain radiation for when there was tumors in the brain that was spread out, but now stereotactic radiation is taken over as the mainstay therapy. Next. So these are some of the concerns and some of the questions, and this is true, that I have been asked in my room to patients or family members. They may not say it to me straight away, but then, they ask the nurse or they send an email after the consultation. These are some of the questions that I've been asked. And so people are worried about radiation. They don't, it's an odd form of medical therapy, I suppose. It's not like a pill that you sort of wrap your head around. But so people want to know if the brain's going to get burned. They want to know if it hurts, will I lose my hair? It's often very important. Is radioactivity a problem? Can I hug my grandchild? Am I going to turn into cancer? Is the radiation going to cause cancer? And then there's all the difference about the technique. Will radiation make me infertile? So that's the most common one in younger patients. Can I have dental work after radiation? Because the dentists around are quite concerned about, because if you have radiation to your jaw in high doses, you can have issues with healing after extraction. So the dental question comes up a lot. Do I need to have an anesthetic? So they're the questions. So hopefully by the end of this, I would have answered all these questions. If I don't, I'll come back and you can ask me again. But hopefully by the end of this talk, we'll go through all those and I'll give you good understanding. Next. So just basics of radiation. The way radiotherapy works is essentially ionizing radiation or X-rays, or also you can also use other forms of radiation like gamma rays, which have a higher energy than what we would usually use, for example, with X-rays for diagnostic scans. And the way radiation works is that it interacts with matter. So it doesn't just interact with the tumor cells, but it also interacts with the normal cells in the body, so normal cells in the brain. But we are quite lucky that our normal cells, they know how to repair damage because we have a repair process in our genetics. But tumor cells, they don't, because they've got this haphazardous genetics, and they basically would know that they after radiation, insult the radiation damage to the DNA, they basically we break the DNA and they won't be able to repair it. Whereas our normal cells, they know how to repair it. As long as we give the radiation in a certain way, and we take advantage of radiology. So essentially the goal is to inactivate tumor cells but protect normal cells by the way we deliver the radiotherapy and the schedule we deliver. Next. So there are variety of different form of radiation therapy machines, and you may have known someone who's had radiotherapy. There's the ZAP machine, there's a LINAC, a linear accelerator, which is the most commonly used therapeutic machine, and it uses photons and KV imaging. And the CyberKnife you might have heard about, the Gamma Knife, they all have sort of some fancy names, some don't. Or there's internal radiation brachytherapy, which we don't really use for brain. It was used a while ago, but it's not used for brain really. So all those, there's different ways of delivering radiotherapy. Again, all of these systems are set up in a way to take advantage of that radiobiological trick where we can protect healthy brain tissue or body cells, but damage the cancer cells or the tumor cells. Next. So just to give you a rough idea of what different forms of radiation do. So just focusing on the brain. So when we, for example, deliver whole brain radiotherapy, which means we do that sometimes when people have secondaries in the brain from primary cancer in their body, and there's lots of tumors and there's lots of activity of cancer in the brain. We don't have any other option than give whole brain radiotherapy that looks after not only what we see on the scan, but also what's subclinical or what's hiding in the cells in the brain. So whole brain radiation, we use a linear accelerator, and we use very primitive, usually it's just 1 or 2 beams from each side of the skull, and the entire contents of the brain on your left side, as you can see, is irradiated. So you can see that left red circle that presents the tumor. That obviously is getting a dose required, but there's a lot of normal tissue in the brain with those primitive radiotherapy fields or very basic radiotherapy fields will get some low dose radiation. Then the more traditional form of radiation, which we have moved on in the last few decades, which is called conformal radiotherapy or IMRT. It's just different ways of delivering it, so it's more focused. It gives us a slightly more focused treatment, as you can see. Not the whole brain is getting those low collateral doses, but it's quite a bit of brain that still gets enough dose to create some side effects. And then the furthest one on your right is stereotactic radiosurgery. And what we do with radiosurgery is that we take advantage of, because we use imaging and rigid immobilization, navigation system, essentially the same navigation system that's used in neurosurgery, to highly focus the beam to the target. So you end up getting really high doses to the tumors, but really, really avoid any of those moderate or low doses to the adjacent brain, which then again, radiology comes in, we end up getting good effect on the tumor, but really minimal effect on the normal tissues on the normal brain. And often it's also a much more convenient treatment because it's a shorter treatment time. So we give it in one session. Next. Okay, so I'm going to go on to talk a little bit about the Gamma Knife, because Gamma Knife is really the gold standard of treating brain tumors. It's a dedicated, so all the other radiation machines I just showed you on the last slide are used for all parts of the body. So all parts of the body can have CyberKnife, all parts of the body will have LINAC or brachytherapy, but the Gamma Knife, it's only dedicated for the brain. So it's a dedicated brain tumor machine, and therefore it has these added benefits that we may not find in the other machines. And one of the main benefits of the Gamma Knife is much more focused. I put a picture of this Swedish man up there. He's a Swedish neurosurgeon who invented the Gamma Knife. He was a Swedish neurosurgeon, in the 50s wanted to treat his patients without opening up to small targets, without having to put them through neurosurgery. And the Elekta machine was essentially built. And in basic terms, what it is, it uses cobalt sources as opposed to what I've described before with LINAC-based radiation, which is photons. And it uses 190 small little sources with highest degree of precision in radiation delivery. So we cannot get anything more precise than the Gamma Knife when we deliver radiation. It's extremely stable because there's not a lot of moving targets. Often in radiation, when the machine moves, the patient can move, the internals of the machine move, but the Elekta, the Gamma Knife does not move. It's got really hardly any moving targets, and therefore we can be super precise. And even the Gamma Knife has evolved significantly over the past many decades. It's widely used overseas as the main intracranial radiotherapy machine. Unfortunately, Australia's been a little bit behind, but we've eventually got there. The first Gamma Knife came to Australia in 2015 at the PA in Brisbane, and we lobbied for one for a few years, and finally in 2020, the Peter MacCallum got a Gamma Knife in Victoria. Next. So these are the sort of indications for treatment tumors we treat with Gamma Knife radiosurgery. And as you can see, it's not all tumors because of its capabilities. We can use it for treatment for things that are not exactly brain tumor or brain cancer. So benign tumors are listed there. The most common ones are meningioma, pituitary adenomas, or schwannomas, or acoustic neurons. From malignant, in the malignant group, brain metastasis is the most common one, and you can see in that pie, the majority of patients having Gamma Knife have malignant tumors. So brain metastasis is secondary, and then there's things like glioblastoma, primary brain tumors, and cancers in the back of the eye. Vascular conditions are also treated, and equally things like we call it functional radiosurgery. So epilepsy, tremor, trigeminal neuralgia, which is a pain syndrome, is also treated on the Gamma Knife. Next. So this is the Gamma Knife team at Peter MacCallum, but it is not a Peter MacCallum or future will see machine. This machine belongs to the entire Victorian population. So it's been funded by the state government, so therefore it's open to every Victorian to come and be referred and use. So we've been operational since February 2021. There's obviously, as it says there, it's covered by Medicare, so there's no out-of-pocket cost. And this is the team. So we've got 3 specialist radiation oncologists. We've got a dedicated neurosurgeon that only works with us. So it's a Gamma Knife neurosurgeon. And I've failed to mention the Gamma Knife is actually used mainly by neurosurgeons in the US, Asia, and parts of Europe. So it's not radiation oncologists, it's neurosurgeons that give Gamma Knife radiosurgery. So it's very much a tool both for neurosurgeons and radiation oncologists. Next. So in terms of the way the Gamma Knife treatment works, the logistics, we start off, obviously as a consult. There'll be a referral. We have a statewide Gamma Knife referral system, and there's a website where referring doctors or even patients can go and have a look at the website and get some information. And there's an online referral page. We then see the patients obviously in the consultation, and often patients are discussed in a multidisciplinary meeting. And if we deem them eligible for Gamma Knife radiation treatment, the patients then invited, we have a discussion and they agree to proceed. They come in for a radiotherapy simulation session, which essentially is a mock-up setup. It's a setup position where we set up people up in a certain position and immobilize the head with a mask. As you can see there, there's a whole lot of the new Gamma Knife system. The Icon has given us this capability to treat patients in a mask system. It used to be we could only do it in a frame, which is a rigid immobilization system, but this is much more comfortable for the patient. It also allows us to break the dose up into 3 or 5 days if the tumor is large. So it's a huge advantage. But it just means that because we want people to we want to achieve that sub-millimeter accuracy, there's some added tools on this machine. There's some lasers, there's a detector on the nose. We use a CT, there's a CT arm attached to the machine that allows us to make sure that the patient is in the right position when we're treating them. So in terms of logistics, we can do everything in one day. So the patient comes in, has the setup, they might have a scan on that day and then they have the treatment, or if it suits better, they might come one day and have the scan and the setup and come and have treatment a few days later. Next. So this is the treatment room. So essentially, the patient, once the setup's done and we've gone through the QA process, we go through a QA process that's quite fairly quick, really, compared to a LINAC that takes 4 or 5 days, because there's a lot of steps before we get to the stage where the patient can go on the bed. And the Gamma Knife is quite neat and the QA process is very quick, so therefore we can do it all in one day. The patients then take it to the treatment room. They've lined up and set up. This patient's got a frame on, and they will then be set up and make that they're comfortable. The patient's completely awake and they can eat and drink prior to treatment. They don't need to be fasting, as I said. They don't need to be worried about anything other than just showing up. They then lie in the bed. We put on some music. The machine goes on. It's completely silent, so there's no noise. We often put music on. And the treatment time varies depending on complexity of the radiation plan, and that includes the size of the tumor and the dose we tend to give. So it can be anywhere from 11-12 minutes to 45 minutes. So it's never much longer than 45 minutes. Yeah, so there's no, as I said, there's no pain, nothing. The patient will feel nothing when they have the treatment. And if there's slight movement, as I showed you, the little laser detectors that place on the nose will detect it, and the patient will then be moved to the right position on treatment. So the treatment can be turned off at any time. So if the person feels uncomfortable or they need to cough or they want to go to the bathroom, we can turn it off at any time. They can go, come back, and we'll continue. Next. This is just showing you sort of what happens behind the scenes. So that's the treatment room on the left. Behind the scenes, there the two. So we got multiple computers on the treatment planning system platform that we work on, and essentially the doctor or the radiation oncologist will define the target. We have radiation therapists and then work on the radiotherapy dosimetry, the doses. Then it's reviewed by myself, and we had physics team to then go through, make sure everything's all the way it should be, and that essentially happens in that room. Next. So, so this is what happens after treatment. Mask off, patients go home, and the most common side effect is tiredness for a few days after. There is no global hair loss, so we really never see anyone losing all their hair. Very, very rarely, depending on where the tumor is. Sometimes when the lesions are very superficial, close to the scalp, there may be slight patchy hair loss in the area, but it's extremely rare on the Gamma Knife. It's more common on the LINAC. So there's no risk of sort of any significant hair loss. So absolutely no radioactivity. So everyone can cuddle their babies or grandchildren or their dogs straight after. And generally, there is no reason to discontinue any anti-cancer therapy. So if a patient is on drug therapy or immunotherapy or chemotherapy, they can start a few days after immediately. Similarly, an operation can happen straight after. So after treatment, we will do a review. As I said, 9 out of 10 times is a little bit of tiredness. People don't have a lot of other side effects. We then do, if it's a cancerous lesion, we tend to follow up very closely with MRI scans every 2 to 3 months. And then there's some rare side effects which relates to a late inflammatory effect on the brain, and that's sort of where we see scarring on the brain on an MRI. It might be 6 months, 8 months, 2 years after treatment, and that tends to be quite rare with low risk of symptoms related to it. The risk of getting a cancer from gamma knife radiosurgery is extremely low. And so with conventional radiation, we tend to tell young people it's 1 in 1,000 to 1 in 10,000. But in the radiosurgery literature, the suggestion is that it's even lower because we irradiate much less normal tissue. So it's around 0.04% at 15 years. Next. So this is just demonstrating one patient's treatment, female with primary lung cancer. And the left side is the tumors prior to gamma knife radiation or radiosurgery, and that's 3 months later. As you can see, most of the lesions have responded extremely well. Next. So for regional patients, the setup is actually much easier than it used to be, and with the gamma knife, it's absolutely 10 times easier, and even for a practitioner like myself, because it just takes away a lot of steps. So we generally, for all our regional patients, we never get anyone to come in anymore. I mean, COVID has helped. Something good did come out of COVID, in that if patients are well and they don't have acute symptoms and we don't need to assess them clinically, we tend to review initially on telehealth and advise. And then if we decide to treat, often we can do it in one visit. So if the patient's from Ballarat, we've had plenty of patients where they just come in for the day. It's an early morning start, so 7:30 a.m. MRI, mask, treatment on the same day. And they go home. So it used to be much harder. Without the gamma knife, we would have to have one visit for the setup and then come back a week or two later for the treatment. So this is just one visit for the whole thing. So as I mentioned before, so all the hospitals in Victoria can attend a meeting, and referrers can present their patients for an opinion, and obviously everyone can get treated on this machine. And all consults, and again, the other thing that we do is a phone consult. We use phone and telehealth if there's if patients are comfortable with that. So there's no need. And we also tend to do the imaging locally. So if a person has had treatment, we want to follow them up. We do an MRI locally wherever they live and contact them with the results. The other thing is also there has been in the last probably 5 to 10 years a growing number of specialized regional centers that give radiation that have more expertise in treating brain tumors, maybe not with gamma knife, but they have, and particularly for Peter Mac, for instance, or at Icon Cancer Centre where I work, the centres talk to each other now. So although the expertise is, for instance, in Melbourne, but we have patients we treat in Bendigo, and because it's all electronic, so I can now treat people in Geelong, in Bendigo, in more like in so many different centres where the machinery is there. Obviously not the gamma knife, but Linacs that have got the specific requirements for radiation treatment to the brain. And that's me.
Thank you so much, Dr. Nita. I'm sure and we hope that this has been quite insightful for our attendees, so thanks again. I would now like to introduce Debbie Butler. Debbie is a mum to 8-year-old twin girls living on Queensland's Sunshine Coast. In 2020, in the height of the COVID lockdown, Debbie discovered her aggressive melanoma had progressed to her brain. She will share her story with us tonight. Thanks, Debbie.
Thank you, Kayla, and hello to everybody that's with us tonight. Next slide, please. Okay, so my motivation for surviving melanoma. So this is my family. That's my husband. It's pretty cliche, but he's my rock. And there are my twin girls. So they actually turned 9 recently. So that's Hannah in the back and Gemma in the front. Next slide, please. So I'll just take a moment to introduce myself. Who am I? So I'm a mum, I'm a wife, there with my husband. That picture in the middle has got my mother behind me and my sister next to me. I'm a volunteer. I do patient support, a little bit of fundraising. I work as an investment analyst for the local hospital and health service. And, you know, in my spare time prior to getting sick, I was just a busy, full-time working mum with with some fun things to do in my spare time. So I like to do some roller skating, some walking, some yoga. I live near the beach and it's quite normal. So life was not quite nice to walk on the beach, and life was pretty normal until I got melanoma. Next slide. Okay, so what is melanoma? So melanoma is the most serious form of skin cancer. Melanoma occurs when the pigment that causes causing cells to give colour becomes cancerous. So if you look on the web, you'll see that it's a skin cancer and it doesn't seem like it belongs in the brain. I got my first melanoma diagnosis in October 2017. And it was a stage 1B melanoma. It wasn't expected to spread, doesn't normally spread. But 2 years later, we found out that it was in my lungs and my ribs. And as Kayla said, in 2020, we found that it had progressed into cranial disease. These are some scans of my brain. They look a little bit like the scans that Dr. Netta showed us. These are some of the metastases that I had in my brain. I actually had 6 metastases in my brain, and they were in every lobe of my brain, pretty much everywhere. Next slide, please. Okay, so what do we know about melanoma? We know that melanoma thrives in the brain. It's expected in Australia that 16,000 people will be diagnosed with melanoma this year. 20% of advanced melanoma patients, so that's patients with stage 2 or 3 melanoma, or stage 4 melanoma, have brain metastases. When the metastatic disease is first discovered. For more than 50% of advanced melanoma patients develop brain metastases during the course of their disease, so that's over and above those ones that had it when we first found it. Back in 2016, the median survival from melanoma in your brain was 5 to 6 months. So if we look at the timeline that Dr. Netta was saying with the Gamma Knife coming in, there's some nice parallels between things improving. Gamma Knife radiosurgery, the response is almost 90% success in killing or shrinking the brain tumours or halting their growth. And that was by 2018. Excuse me if I stumble over some numbers, that's just a little outcome from being sick. So game changer, I had 6 brain mets. The largest was 23 millimeters. The second largest was 22. I was treated with Gamma Knife at the Princess Alexandra Hospital in Brisbane in April 2020. I had a PET scan, and that's a combination of PET scan and MRI with a very special tracer in June 2020, and that showed no active melanoma. Next slide, please. Okay, so what was my journey on the day that I got Gamma Knife radiosurgery? So I often tell people Gamma Knife radiosurgery is the simplest treatment I've ever had for metastatic melanoma. So I arrived at the hospital at 6 a.m. in the morning, and I'm one of those regional patients that had to travel down to Brisbane the night before. I was given a Valium to relax, and the frame was attached to my head. And I think we saw a photo of it. It's not a very pleasant experience, and that was the worst part of it. It was over. I was given a CT scan to check the placement of the frame and an MRI to check how my mets were. Unfortunately, mine had doubled in the last fortnight and they were almost too big to treat, but I just scraped through. So some planning was done by the radiation oncologists, and then I was put into the Gamma Knife machine, and it was similar to getting an MRI. So I think it was about 9 to 10 minutes I met, and I was there for about an hour and a half just listening to some music. At 4 o'clock, my husband picked me up and we stopped to get some steroids on the way home and went home to relax. And then the next week I could continue with my immunotherapy. Now I was on ipilimumab and nivolumab, and that's quite a strong combination of treatment. It's quite tough treatment. So I was able to get back into that in 5 days. Next slide, please. Okay, so how invasive was the treatment? Well, on the left, what we have is what would happen in a craniotomy. So this is what would have happened if those Mets got any larger and I could not have had Gamma Knife. So they would have to, sorry, let me get to the right one. They would need to cut through the scalp, the muscles, the skull, the dura to get to the brain. Now I had metastases in 6 places in 4 different lobes. So they certainly would have had to have significant cutting. What I did end up with is on the right, and that's a stitch in the front. We had some clever placement of the frame because of one of those frontal lobe Mets, and it fractured my upper sinus. Next slide, please. More on the invasiveness of treatment. So this is me in an ambulance the night of my Gamma Knife surgery, going back to hospital. I had a little bit of brain swelling and I was told to start my steroids the next day. So that resulted in some uncontrolled migraines and vomiting. I went to the ED. They gave me some fluids and some steroids and sent me home. If I had traditional brain surgery, which is still done a lot, I would have spent probably 3 to 4 days in hospital. Next slide, please. Okay, complications. The main complication for me was aphasia, which is a difficulty finding words and saying numbers is how it continues for me. That was caused by a bleed on the brain. And at the time I had quite a significant cognitive decline. I couldn't finish sentences. I couldn't find words. Whatever functions are managed by the part of the brain where your brain, where the Gamma Knife surgery takes place, or where your brain met is, will, are the functions that you might lose for a bit. But I had 3 weeks of getting really sick, and then I had 5 weeks of getting better. I was one of those lucky ones that got a little bald patch, and there's a picture of mine there. And that was because one of my Mets was pretty close to the skull. So it got a bit of radiation there. I had fevers and from swelling in the brain, and I was hospitalized twice with that. My brain took a lot of radiation because I had 6 large Mets. So it was a tough time for me. And then there was that fractured upper sinus because of the awkward or difficult placement of the frame. Next slide, please. But the outcome. So I finished treatment after 2 years in February 2022. My PET and MRI scans remain clear of active cancer. So I've still got 2 very small dead bits of melanoma in my brain, but they're not active. We do an MRI on them every 4 months to check. So, with the advances in systemic and localized treatments, metastatic melanoma of the brain can be resolved, and it doesn't need to be a terminal condition. And thank you for your time.
Thank you very much, Debbie, for sharing your story. I would now like to introduce Dr. Jane Phillips. Jane grew up on a sugarcane farm in northern New South Wales and moved to Sydney to go to medical school. She's still there and is now a mum to 2 high school girls and is a keen runner and musician. She works in the public health sector. Jane will share her experience with acoustic neuroma. Thank you so much, Dr. Jane Phillips.
Thank you, Kayla. And thanks for having me tonight. As Dr. Netta said early in her presentation, Gamma Knife can be used for all sorts of conditions, including benign brain tumours, and that's been my experience. So I just wanted to share a little bit about my experience and how it was similar, and I guess how it was different from Deb's experience with Gamma Knife. So I'm a doctor. I work in tuberculosis control, so brains are not my thing. I don't know a lot about them, but I did know in medical school that the one thing I thought, after seeing all the conditions available to humans, that the one thing I would not be able to cope with was a brain tumor. And so I just had some tinnitus and ringing in my ears, and I went to my GP thinking I was going to get my ears syringed. But to cut a long story short, I was sent for an MRI, and being a doctor, all the things that can go wrong do go wrong for doctor patients. And so I was the last patient of the day. Everyone was busy. So instead of my report being, my MRI being reported, the scans were just handed to me. And you can see on this slide, there's a building in the middle down the bottom. That building is the Woolworths at Crow's Nest in Sydney, if anyone knows it. And that is where, being the bad patient, I opened my scans at that bus stop outside the Woolworths. And what I saw was on the right, a big white thing where I knew there shouldn't be one. And so this was the weekend. It was a Friday afternoon before Mother's Day. So I had the whole Mother's Day weekend not knowing what this was, sending pictures to my friends and family and colleagues. And most of them said, look, it's probably not a big problem, but I can't really say. And so that was a very, very long weekend. So next slide, please. So this looks boring, and the takeaway from this slide is that when you have something in your brain and you're looking to work out how to be treated, different things are going to be important to different people. And for some people, that might be how you're going to function afterwards. It might be downtime. It might be pain. It might be, there's so many things that matter differently to different people when it's you. For me, I was 36 when I got that MRI result, and when I found out that it was a vestibular schwannoma or an acoustic neuroma, I knew that if things went well, I had a long and productive life ahead of me. And so for me, what mattered a lot was the radiation dose. My mind is really important to me. I enjoy using it, and using it at work and outside work. I'm a musician, and it was really important to me that the risks of a secondary brain cancer caused by radiation was low. I was offered standard LINAC radiation for my tumor. I was also offered an open surgical removal of the tumor. But what was important to me was low radiation dose, and Gamma Knife offered a far more targeted, far lower radiation treatment. It was a day treatment, and it really appealed to me as a mum, and also as a doctor and as a patient. So next slide, please. For me at the time, this was a little while ago, before there were many machines in Australia. And for me, I live in Sydney. There was one machine in Sydney, and it was not a publicly funded machine. I could have gone to Brisbane, and I would have been one of the first patients with my particular condition to be treated. But the team in Sydney had treated quite a few people with the same condition. And I felt more comfortable being treated in Sydney by the team that had seen more people like me. But because the machine was at a private hospital, I needed to pay out of pocket for my treatment. So it makes me so happy when Dr. Netta talks about the number of machines available and how people can access this now, because I chose to pay $26,000 out of pocket for my radiation. It was worth every cent. And the fact that this is available through Medicare, although there are some out-of-pocket costs, the fact that this is so much more accessible is it's just a really humane and good thing as patients in Australia. So next slide, please. So this was my treatment day. A bit like Deb, the frame was still in existence when I had my treatment. similar experience to Deb, except I just had one area being treated. But I put these pictures in here to show that you can still eat. That was a peppermint slice. It was amazing. And because this day was, costing more than my first university degree, I was going to eat all the foods and have all the fun. So it was actually a pretty nice day. It was relaxing. The staff were wonderful. Despite the frame, which was uncomfortable, it was a really good experience. And a bit like Deb, I went home with a bandage, got some steroids, and felt okay. Felt pretty good afterwards. So next slide, please. So here on the left, this was my tumour after the first treatment, and then on the right was, I think, was 2 years after. So you could see the tumour was starting to break down in the middle. Oh, that was, sorry, a year post. So the Gamma Knife was incredibly successful for me. The tumour is still there, but it is smaller and not causing any any problems within my skull. So it worked. Next slide, please. Again, a bit like Deb, it's always good to be realistic about what actually happened in my situation. So a year after my Gamma Knife, I was running a race, 10K with my daughter. That's us up on the left there. I also have a high school age son, but his face can't be shown anywhere on social media because he's 15 and won't let me. So we were running a race and I became really dizzy at the end. And because the radiation had been so successful, there was just some fibrosis in my brain, and it caused an impingement of the blood supply going to my middle ear on the left. So I had a stroke that caused some balance and profound deafness, balance loss and profound deafness in my left ear. But the amazing thing was that my facial nerve was preserved, and that was something that I was so concerned about. If I'd had to have surgery to remove this, that I would have had a facial droop for the rest of my life. So to be honest, losing my balance and hearing was the better of two evils. And it was just the way things happen for me. And you can see on the right there, top right, that's me practicing drinking wine and standing on one foot as part of my vestibular rehab. It's unorthodox, but it worked. And going to the physio, you can see my walking stick there. And I had to paint my big toenails blue to give me something to focus on when I was relearning to walk normally. Bottom left was me just after my stroke. The kids took a lot of unflattering photos of me at that time, and that's what children are for. So next slide, please. This is where I was going to finish up. So for me, recovery took a little bit longer than you would traditionally have from Gamma Knife, because I had a very particular rare complication. But for me, I'm orchestral percussionist, and getting my hearing back a year after my stroke, I had a cochlear implant and was able to hear properly for the first time again. And the picture on the left was when I played with the New South Wales Doctors Orchestra in the percussion section, and that felt like the end of my Gamma Knife treatment journey, that I was kind of back to myself. The other good thing about having my hearing back and having a cochlear implant is that I have a magnet in my head, so the kids can pin things to my head with fridge magnets, which, endless entertainment. Next slide, please. Yep, so that was all I wanted to say tonight. So thank you for listening, and yeah, I'll just hand it back to Kayla.
Thank you so much, Jane. As mentioned, Jonathan is sick tonight, and Kevin will be speaking on his behalf. I will just flag that we're running a little bit over time, so Kevin will just quickly summarise Jonathan's slides whilst we then go to the Q&As. I will just quickly say Jonathan is a nurse with 10 years of specialist experience with cancer and palliative care, and he brings a wide range of additional non-medical education and life experience to his role as a brain cancer support worker. So please do stay with us as Kevin, on behalf of Jonathan, closes out before the Q&As.
Thanks, Kayla, and thanks particularly to Nita, Debbie and Jane for those presentations, which puts a context around Jonathan's work. I'm a very, very poor substitute, I can tell you. It's probably 2 years since palliative since Peace of Mind have been trying to get this position, and it was only 12 months ago that we secured the funding to be able to employ a dedicated community-based brain cancer support worker. And I think Jane's story about standing outside Woolworths probably is a great representation of what Jonathan does. In other words, he goes to where people are. And it's not so much what happens in the consulting rooms that matter as much as what's said in the kitchen, in the cafe, in the time outside the experience. And the brain cancer support worker, Jonathan, does that. A couple of examples of what he does is he has time to spend with people. We call him the navigator. He helps people navigate a system that it's at times is overwhelming. And his experience as a palliative care nurse and as a nurse himself, that's Jonathan there, and that's the car that's very recognisable around Geelong. But what he does have is time to spend with people and to find what it is they need. And there are no no-go zones. He also is very capable of assisting with the really difficult conversations. We have a passion for this, and we also have a vision that brain cancer support workers who can walk alongside families, individuals, and be with them at any time for any purpose. And Jonathan does that. We arranged for one patient to have a coffee in a large vehicle, in a wheelchair, at Point Danger in Torquay with the family. We arranged for someone else to have a helicopter ride, which was her wish. Another couple who hadn't in 3 years been outside the home. The connections that Jonathan had, and we were allowed for them to have a night at Dalesford. It's those sort of things that make the difference. It's not just the helicopter ride, it's not the coffee, it's the connection. And Jonathan is connected to currently 40 odd individuals and families in the Bowen region. And it's our passion to see his position replicated in every region in Victoria and eventually in Australia. In economy of time, I think, Kayla, that's probably enough. And I'd love to say more, and I know Jonathan would. But it is, I think, a real game changer in this space where you have a dedicated person who not only can stand alongside, but is competent, confident, informed, and becomes trusted.
Thank you so much, Kevin. And if attendees do have more questions, they can also reach out directly to the Peace of Mind Foundation website. As mentioned, we will now head to our Q&As. Dr. Nita will be answering majority of these questions, and I will signal to other panelists if questions do come through to them. So let's get right into it with the first question for Dr. Nita. Can you have gamma knife radiation if you have already had full brain radiation previously?
Yes, you definitely can. So that's in fact the primary way of salvaging recurrence of particularly brain metastases. So usually we've had whole brain radiotherapy. I tend to say whole brain radiation has got an expiry date. It's sort of usually between 6 to 12 months because it's not high doses we can give. So therefore there's sometimes, or most usually, there'll be a recurrence after 12 months, and we use radiosurgery or gamma knife radiosurgery to do to treat those new tumours.
Next question, when do you know if radiation works?
So generally radiation takes, again, radiology, so it takes a little bit of time for the process. So we would say that generally for benign tumours takes a bit longer, but for cancers we tend to say around 3 months. And often I say to patients, because people are anxious and they want to do a scan, I always say, if you feel better, then it means that it's working. So sometimes clinically people improve without us being able to see a change on a scan. And so the scan is not always the truth, but minimum 3 months before we can see a measurable response.
What makes a patient eligible for Gamma Knife?
So I listed some of those indications, but Gamma Knife really, as I said, it's an intracranial machine for intracranial targets. So I often get asked if we can treat things in the spine or below the bottom of the brain because it's a part of the central nervous system. And unfortunately, we can't, because we're limited to that. The capability of the imaging that is just under the bottom, the base of the skull. That's as low as we can go. So the best targets for Gamma Knife radiosurgery are tumors that are confined and relatively small. So when things get bigger than 3 centimeters, Gamma Knife radiosurgery is not always advantageous. And not because we can't do it, it's just not maybe as safe in certain cases. It's not as practical. So for large lesions, say in the skull base or large tumors in the brain, the treatment will take longer than we do on a LINAC, where we can treat maybe something in 20 minutes, and on the Gamma Knife might be over an hour because it's a larger tumor. The other times where Gamma Knife is not a good treatment is when the primary or is primary brain cancer or secondary brain cancer, where we know that the distribution is that the tumor grows in a diffuse manner. So some tumors like gliomas, they can be quite diffuse. So even though we see an abnormality on a scan that's maybe only 3 centimeters, we know that about 2 centimeters beyond what we can see, there's tumor cells. So by only treating what we see on a scan with the Gamma Knife, we're missing out on it. We're leaving a whole lot of disease behind. So therefore, commonly gliomas, for instance, are not suitable for Gamma Knife treatment because they have this diffuse way of growing, and we need to treat large areas of the brain. And the safest way of doing that is breaking the radiation dose over several doses over several weeks to achieve that. And we don't generally do that on the Gamma Knife. But otherwise, tumors that are small in the skull base, all very, very suitable for Gamma Knife.
Can children have the Gamma Knife treatment?
Yes. So we've actually had, we've so far treated two children, and they had benign, so one of them had a vascular condition, so had a vascular abnormality that we treat with radiosurgery, and the other one had what's called a hematoma, which is an abnormality in the brain that causes seizures.
How intrusive is a biopsy of a tumor in the right frontal lobe?
Right frontal lobe is, if a person is right-hand dominant, the right frontal lobe is a non-dominant part of your brain. So it's the least sort of important part of the brain. So you can sort of lose quite a bit of it without you really sort of noticing much. So biopsy is relatively safe. The right frontal lobe is not a bad area for a biopsy. It's pretty, I'd say is very safe compared to other parts of the brain.
What is the best treatment for metastases to the brain after radiation caused by radiation necrosis?
So repeat that again. So
what is the best treatment for metastases to the brain after radiation caused radiation necrosis?
Yeah, so it sounds it's a bit contradictory, but it's radiosurgery. So it's Gamma Knife radiosurgery. So radiosurgery, whether it's on a LINAC or a Gamma Knife or a CyberKnife, because of the high doses that we use, can cause radionecrosis. Radionecrosis is really the only main side effect, long-term side effect from radiosurgery to brain metastases. What it basically means is that it's a delayed inflammatory response in the adjacent brain where the radiosurgery was delivered. We often pick it up as an abnormality on a scan, it often is a bit, we never know whether it's tumor or radiation necrosis. There's some features that suggest radionecrosis. Most of the time, people don't have any symptoms related to it. It tends to have a self-limiting pattern. So it tends to sort of peak and then settle or go away or just settle down to some abnormality we see on the scan. We always know it's radionecrosis when it stops growing, because tumor always grows, but radionecrosis just stops, and we say to the patients, don't worry, it's just radionecrosis, we do nothing about it. Now, the risk of getting radionecrosis from radiosurgery in general is somewhere between 15 to 20%. And of the 15-20% of people who get it, only 5 or 6% get symptoms. And it also depends on where it is in the brain. So if you get radionecrosis in a very important part of the brain, say eloquent brain that is responsible for movement of the body, a tiny bit of swelling around that inflammatory response can cause symptoms. Whereas if there's radionecrosis in the right frontal lobe that's not so eloquent, people won't even notice they have it, they move on, and it goes away on its own. So having had radionecrosis in one side doesn't mean that you can't have radiosurgery to other parts of the brain. So if you've got a new brain metastasis after having had radionecrosis, it's not, as I said, the odds are still the same. It's still a 15 to 20% risk of getting radionecrosis. Your risk of getting a new of radionecrosis again is not high just because you've had it in one area. So yes, so if there's a new metastasis in the setting of prior radionecrosis, remotely from where the abnormality is, yes, you can have radiosurgery or surgery for that matter. Yeah.
Is there anything that can be done to retrain your brain after surgery to help with memory fatigue or sensory issues?
Yes, there is. There absolutely is. I think, I mean, it depends on the scenario, and a lot of other, it's very multifactorial, these symptoms. You know, it's not just surgery, but it could also be because the person has had a tumor in a particular part of the brain that processes information, could be because they've had radiation, could be because of the drugs. So the chemotherapies, immunotherapies, all those drugs also cause those side effects. So, but there is, you know, often an assessment by a neuropsychologist is quite helpful, because what they do is they assess, they identify the deficiencies, and they give really good tools in how to manage that, and some people can improve.
Could you provide any information around access to clinical trials?
Well, it depends. There's a lot of clinical trials for lots of different things. So, yeah, so big sort of academic centres, the VCCC, the Peter MacCallum Royal Melbourne Hospital, it's got a big neurosurgery unit, Icon Cancer Centre at Epworth Richmond in Victoria. All those big academic hospitals have variety of different clinical trials. Some of them are international, some of them are national, some of them just you know, small trials where they're just happening at that hospital. But it really depends on what the disease is, you know, what the situation is. And everyone has access to them. So, you know, when you see a practitioner, it's always good to ask.
Are there any other new treatments to make note of?
There's always, again, that depends also what we talking about. Are we talking about primary brain cancer? Are we talking about brain metastasis? Are we talking about benign tumors of the brain? There are always new treatments in the medical, so systemic therapies, mainly not for benign tumors. I'm only talking about cancer here. There are always trials ongoing, and even the immunotherapy that Debbie had, where she had the double, that wasn't really available until about 5 years ago. So that we knew that one drug worked, and there was a clinical trial that showed that two immunotherapies together had extensive response rate in the brain, and it now has become standard of care. I'm a PR on a clinical trial now where we're looking for melanoma brain metastases that the immunotherapy alone, so we don't even give radiosurgery anymore. Should we just do immunotherapy, or should we do immunotherapy and radiosurgery? So that's just one example. So in terms of, so it's not so many new things, but it's new sometimes sequencing of new way of doing things to maintain efficacy, but reduce the risk of side effects to patients, for instance. So there's a new sequencing approach around radiation and brain metastasis surgery that I've been doing since 2018, and there's data now coming out now, because we always give, for instance, after an operation, we give radiosurgery to the tumor bed to reduce the risk of recurrence. And now the novel way of doing it is to do it before. And there's trials ongoing looking at, should we give radiation before surgery? So that is constantly happening, but there's no new magic tablet or new magic radiation machine that's fixing everything that, that's out there. No.
Thank you so much, Dr. Netta.
No.
We'll have one more question, and we'll direct this to Jane, and then we'll direct this to Debbie. The question is, what was the best form of support you received during the process of treatment?
Oh, thank you. That's a really good question. I think for me, because it is so minimally invasive and it's an easy treatment, on the treatment day, it's I guess it's easy for people to think that you've had nothing done, and that's not how it feels when you've got some swelling in your brain. And as Debbie said, things just feel, it's difficult, and people can't see any scars or bandages on you. So I think for me, the best support was telling people that I'd had this done, because if I didn't, they wouldn't know, and that helped them realize, that I did need more time and I needed time off work and support. So for me, it was really explaining to the people around me what the procedure was, and and letting them know that I might not look too bad, but I don't feel great for the couple of weeks afterwards. Thanks, Kayla.
Hi, Kayla. Look, for me, I was incredibly lucky that I had an immense amount of support, but there were probably three things that probably really stood out in that support for me. The first thing, because my treatment was 2 years of treatment and it was quite grueling, the Gamma Knife was the easiest part of it. So the first thing was that I had a nurse coordinator, and at the slightest sign of anything that bothered me, I could contact my nurse coordinator, and she would have an answer for me. If she had to go to my oncologist, she did, but she would always have an answer very quickly. I also had a psychologist, an oncology psychologist that was provided by the hospital. And when I was getting the Gamma Knife radiosurgery, and I was really distressed about the thought of cancer in my brain, and so much cancer in my brain, my oncology psychologist called me every week. Every week she called me for weeks and weeks when I felt like I was dying, when I got really sick. And the third is the melanoma community in Australia. So there's quite a nice melanoma community in Australia. There's always someone that's been through what you're going through. And that's why organisations like Peace of Mind are so important, because they allow you to connect with other people that understand your experience, have been there, and can provide some advice. So they would be my top three.
Thank you so much, Jane and Debbie. We are right on time. So I'd like to thank all our panelists, Dr. Nia Hagigi, Debbie Butler, Dr. Jane Phillips, our Peace of Mind representatives, as well as the support of Elekta to have achieved this live webinar this evening. This session will be recorded, and this will be available on the Peace of Mind website in the coming days. We wish you all the very best in your treatment journeys and loved ones. We hope you are feeling empowered to ask more questions and consider the option that might be right for you. Thank you so much for joining us, everyone, and all the best. Good night.